Let's move from Canada to Aragon, a region in the northeast of Spain. As we have seen during these days, in the end, population health management entails bringing a population perspective into clinical practice, right? Working at the interface between both individual and population services at community level. And we often see a gap there. And here's where we think that public health services can play a very important role. So in our next presentation, we are going to see how the actionable information provided by public health services helps primary care teams carry out needs assessment, define priorities, and also deliver care together with communities. So for this presentation, we have two people with us. We have Bárbara Quevedo Benito, who is a family doctor with a master's degree in emergency, who currently works in the surveillance and immunization service in the General Directorate of Public Health of Aragon. And with Bárbara, we have Belén Benede Azagra, who is also a family doctor with a PhD in public health. Belén works in the Directorate of Health Planning of the Department of Health of the Government of Aragon, and she coordinates the community care strategy in primary care. So without any further introduction, Bárbara, Belén, the floor is yours.
Thank you very much for the invitation to participate in this event. On behalf of all the people in Aragon, in Spain, who are working to improve the community orientation of primary healthcare. Aragon is an inland region in the northeast Spain, comprising 3 provinces. Aragon is home to just over 1,350,000 people. It is a large region compared to the rest of the region in Spain and has a very low population density. More than half people live in the capital, which is called Zaragoza. There are more than 700 municipalities, many of which have less than 500 inhabitants. This territorial structuring is sometimes not easy for public services, and health services also suffer from these circumstances. Aragon has a health system which is organized in 8 health sectors. We have 124 basic health zones that have this number of primary health care, which can sometimes be responsible for more than 10 population, with a lot of dispersion, especially in rural areas. Well, in primary care, we not only care for people individually, we are also responsible for the community they live in. People live in a specific context, as with certain living conditions. To have this living condition present is very important in all individual or collective care action, which we can carry out or plan it in primary care. And that's the reason, because it is necessary to develop in primary care a look at the causes of the causes and at the social determinants of health. This way of looking or doing is what we call developing community orientation of practice in primary care. In this slide, we can see the definition of community care in primary care. This is the definition of the service in our portfolio services of the Spanish National Health System. In Aragon, we are developed since 2016 the community care strategy in primary care to develop community orientation of primary care. In order to achieve this, it is essential to take into account the social determinants of health. This strategy is part of the health plan of our regional health system. It is led by primary care together with public health and participation. This coordinating group works closely with other areas of the Department of Health, as well as with other departments of the government of Aragon. And how we propose the development of this strategy? Well, in order to develop it in Aragon, we have proposed 3 ways of action and 5 coordinating actions. These 3 converging lines of action propose a roadmap, but with respect for the context, reality, and narrative of the primary care centers, so that they can be incorporated into it. The primary care teams are organizing themselves internally and adapting their individual and collective care and attention actions. They develop their own community agenda, their internal and external participation groups, their individual and collective care programs aiming at health determinants, or even develop formal social prescribing scheme. One of the most important coordinating actions for the development of this strategy is technical support with specific tools. One of them is the Health Atlas, what we present today, and which allows primary care teams to develop their action aimed at health determinants and health opportunities. My colleague, Barbara Quevedo, was there to take a closer look at this atlas.
Good morning. I would like to introduce you the Atlas of Public Health Surveillance of Aragon. Information on population health status and its determinants, it's usually provided for large geographical areas. However, there is a need to assess, guide, and update information on specific population, and because of this, it's necessary to make their possible differences and inequalities visible. For this reason, was created the Atlas of Public Health Surveillance in Aragon. The Atlas is a digital tool that provides information on the health status of the population and its determinants by basic health zones, ZBS, that are small territorial areas and the first level of action of the health system. This division is of great interest because it allows to assess the health situation of an area, potentially contributing to guiding the implementation of prevention, protection, and health promotion actions. It was developed by the Geographic Institute of Aragon for the General Directorate of Public Health. When we access to the Atlas, we observe that the information is offered to us in two main sections. The areas of interest, where we will see the consulted information represented on an interactive map with data analyzed by ZBS, and information by ZBS, where by selecting a specific ZBS, all calculated indicators are displayed, providing an overview of the health status of the selected ZBS. The areas of interest are divided into four main sections that provide information for each of the ZBS. We have health determinants that are factors related to the health level of people and population, also have morbidity and mortality, and these three sections provide information on health determinants and status. And then we have health resources and assets, understanding assets as those resources recognized by the community as valuable. They improve the ability to maintain health and well-being and help reduce health inequalities. In this table, you can see the different categories included in each area of interest and currently shown in the Atlas. This information comes from both health and non-health database. When we query one of the categories, for example, hypertension, as you can notice in this example, we will see a thematic map that shows us the selected indicator for each of the 124 ZBS, into which Aragon is currently divided. The ZBS are colored from green to red, representing the value that corresponds to it when it's divided into quintiles. The menu allows us to choose the year, sex, and indicator that we want to see represented on the map. In most categories are represented these three indicators: rate per thousand, REMS, and probability of excess risk. In addition to the usual rate, we calculate two other indicators in order to be able to assess our territory in a global comparable way, because Aragon has a high depopulation. For this reason, and to eliminate the influence of factors such as age and sex and population size, we calculate the REMS and probability of excess risk. In other categories, such as health determinants, the indicators used are percentages. For example, overaging, which represents the proportion of people age 85 and over in the population age 65 and over. Another indicator included in the determinants is the deprivation index, which is designed to objectify health inequalities between the different ZBAs based on data from the latest available census. The index summarizes important aspects such as education, employment, occupation, and demographics. The census has been recently updated, so we are working on calculating a new deprivation index. In addition to this tool, this tool allows us to observe the historical series, that is the evolution of each indicator for the different ZBS over time. On the web, under the map, we can see our query in a form of a data table divided by ZBS and complete list of the values of all the indicators of each dimension. As you can see, the colors correspond with those observed on the map. If we continue scrolling down, we can see links to reference documents that provide more information of the indicators and explain in detail the methodology, limitations, and strengths of the tool. As I mentioned before, another way to consult the information offered by the atlas is to search for a specific ZBS, which we would do by clicking on this icon. Here, we could filter the information by ZBS and sex. The latest information available for each indicator is shown following the same color scheme that we have seen on the map. All the information, both by indicators and by ZBS, can be downloaded to be used by anyone interested.
Let's look at an example very quickly. This is the Aliaga health area. Aliaga in Aragon is a rural area. The health center serves 800 people spread over 15 localities. The team of professionals at the healthcare center wanted to improve their community orientation. To this end, they joined in the community care strategy. This made a group, and they made them ask themselves questions about their health area, so that they could respond more effectively to health needs. And they took a look at the health atlas. Search and have a look. And they obtained data for the area on social determinants of health, morbidity, mortality, or community resources. And with what they analyzed at that time, they decided to try to organize projects to address obesity in this case, but with a focus on the social determinants of health and with participation, engage people. And they create a formal scheme of social prescribing with other agents in the territory. They have continued to work in a community-oriented way, taking into account the living condition of the people, which has made them able to respond to the challenges with concrete and more effective and efficient actions and different projects. Some of them, like the Healthy Springs of Aliaga, in which they have addressed many issues more than obesity, such as mental health or others. And it all started by taking a look at the map. Thank you very much.
Thank you very much, Barbara and Belen, for your very good presentation. I think that I like very much how the information that primary care teams have is disaggregated precisely at their level of action, in the catchment areas. I think that this is something that is very powerful, and I also like to take the advantage to emphasize from your presentation the fact that this is really supported by adequate policy strategies like the ones you have presented at the very beginning. Mechanisms, I know that you have mechanisms for social prescribing as well, institutionalized and funding. And this is something to be taken as serious as any other clinical process or pathway that may take place in primary care. So thank you very much. I'm sure that there will be questions at the end for you as well.
Question goes to Belen and Barbara on what they presented on mapping like hypertension, and one question is going that this kind of risk factor mapping like hypertension is exactly what was registered. So we have registered hypertension, yes, and the prevalence of first diagnosis of hypertension and so on can encourage unnecessary focus for this who already have registered hypertension, and to some extent we can miss lower socioeconomic groups with lower health literacy who has not diagnosed hypertension. And that was also coming comment from Esteban that sometimes when we depend very much in decision making on existing data and not account missing data, so that is also could be examples that we we're missing from lower socioeconomic groups data because they are not using services, they delay in addressing their problems for different reasons. So is it an issue, and how you can respond to this question?
But when you look at the map, you can also see when things don't fit well. For example, we know in our area where we have the more poor people. So if we see that population is too healthy, we can see that something is going wrong, and we have to do something because that can be real. So also, even if you don't have numbers, if you don't have information, that also gives you information, because you can see what doesn't fit well. You can see that in other places, for example, putting the example of Zaragoza, you can see that in places where the people has more resources, you have for example, you have more hypertension than in other places where you know that they have less resources and their health is less good, and you see that the numbers doesn't fit well. So that also gives you information to go to that center, to that health center, and says, what's going on? What do you see that we can see, because we are not working here, we are not connecting with the people like you do every day. So I think that even if we don't have numbers, that gives you information too.
And
exactly.
And I would like to add that we should think that is a tool. That is not the
reality,
the end of our action. So the atlas, or this kind of type of atlas, is a way of collect the data of different database, and to put for the teams in the primary care health center. That is true that it's very occupied and with a lot of work. So in our experience, this atlas gives the opportunity to these teams to have a look very quickly and what has happened, and to reflect that maybe the idea that the people, the professional of the healthcare center is not the real. What I mean is that normally as a GP, sometimes I have just the vision of my patients. But when you see our health area, you can see that what happened in the area.
To all the population, not
exactly.
Only your...
And if you put the focus, for example, in hypertension, but you are thinking to work with people who have hypertension that are lonely with loneliness, maybe the atlas give you some dates that you can, and always this atlas give you some illness view, but it allows to you to change your look, because the atlas offers to you the assets in the part of resources, health resources, with people who in your health area are working for another way to face the things. For example, the part of schools with projects on health, for example. And all these tools, that's quantitative tools, this group of primary care in the health centers is an opportunity too, with another stakeholders in the areas, to do a diagnostic more qualitative, with put into it the perspective of people, of the stakeholders that maybe are resources to face the challenges that we have to improve the health of people.
I think Fantastic. I think it's very good response, and it's aligned with what Mark now writing in the chat, that data are supportive and combination of information is useful. So of course you can combine hypertension map and with socio-economic map where and you see how really correlates this data about hypertension between different socio-economic groups. That is exactly what is needed. And also you, on the last messages, thank you that you added the qualitative studies, because that is exactly that we need to combine data with insights from community and what they see and so Spark tool is one where you're getting voices from community, but of course you can use qualitative data to get voices from community and prioritize and needs, combining data.
It's something that it's always moving, and when someone sees a map, when I say someone, I'm thinking about a GP, when they consult the map, and if they see something that doesn't fit, well, I was saying that before, they can ask to us. They can also see their work, because the atlas, it's fit with the information that they give to us. So really seeing in a tool that your work, your effort is becoming something real, that someone is taking it's taking you in what, sorry, I don't have the word. But
I think, yeah, I think it's clear. I think it's clear, and your presentation was quite comprehensive, and this clarification now put everything in clear for participants. Let's move to one more before I move to the next question, which will be to Andrew in the chat. I kindly ask all participants who see that their question in the chat was not seen. Please repeat this question. Repeat this question if you want to get response. And also, thank you, Barbara Carmen.